Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we're exploring advances in pulmonary hypertension as well as symptoms, treatments and its connection to rheumatological patients and much more. This podcast is sponsored by Macquarie University Hospital, part of MQ Health, a trailblazer in healthcare, education and research. Associate Professor Martin Brown is a cardiologist specialising in advanced heart failure, complex structural heart disease and pulmonary hypertension. A clinical associate professor at Macquarie University, he currently leads several international trials on heart failure and pulmonary hypertension and has developed the Right Heart Catheter virtual reality training program being used worldwide. Associate Professor Fred Joshua is a physician specialising in rheumatic diseases, including rheumatoid arthritis, ankylosing spondylitis and psoriatic arthritis. He pioneered rheumatological ultrasound in Australia and developed a degree for rheumatologists through the Australian Society of Ultrasound in Medicine. He is an Associate Professor of Medicine and the Rheumatology Clinical Discipline Head at Macquarie University. They join me now. Associate Professor Martin Brown, pulmonary hypertension is a complex condition affecting both the heart and lungs. Can you give us an overview of what it is and how it develops?
Yes, thanks, Sally. Pulmonary hypertension is elevated pressure of blood flowing from the right side of the heart through the lungs and back to the left side of the heart. This increased pressure forces the heart to work harder to pump blood through the lungs, which eventually causes right heart failure. It can be predominantly right-sided, what we call pulmonary arterial, left-sided, called pulmonary venous or post-capillary, or a combination of the two, called combined pre- and post-capillary. The symptoms often develop gradually and may include shortness of breath, fatigue, chest pain, dizziness, but mainly swelling of the legs and the abdomen. And there's no cure, but treatments aim to manage symptoms and improve patients' quality of life and hopefully slow disease progression. There are 5 main classifications or groups of causes. Group 1, pulmonary hypertension, is due to small blood vessel inflammation and narrowing caused by idiopathic pulmonary arterial hypertension, hereditary pulmonary arterial hypertension, and PAH associated with connective tissue diseases, which we'll go into more detail later with Professor Joshua, congenital heart disease or drug-induced PAH, such as diet pills and amphetamines or cancer treatments. Group 2 is caused by back pressure from the left side of the heart, such as heart failure, cardiomyopathy, or valvular disorders. Group 3 is due to lung vessel damage directly from diseases such as emphysema or pulmonary fibrosis, or chronic vasoconstriction from low oxygen levels such as sleep apnea and hyperventilation. Group 4 is due to multiple blood clots within the blood vessels of the pulmonary artery obstructing blood flow. We call this chronic thromboembolic pulmonary hypertension. And group 5 is a mixed bag of other conditions such as sarcoidosis and blood cancers.
Tell us, Martin, why is pulmonary hypertension such an important condition for both the public and healthcare professionals to be aware of?
Pulmonary hypertension is a rare condition that has little awareness currently and often goes undiagnosed until it reaches advanced stages. For the public, understanding PH can empower them to recognize the subtle early symptoms that are often misdiagnosed or not recognized and seek medical evaluation sooner. This is important because early diagnosis can make a significant difference in managing the disease and improving their quality of life. For healthcare professionals, particularly general practitioners who are the first point of call, awareness is critical because PH can mimic or coexist with multiple other conditions, which makes it challenging to identify. Delayed or misdiagnosis can lead to serious complications, including severe heart failure. Furthermore, PH requires multidisciplinary approach because it can often involve cardiologists, pulmonologists, rheumatologists and/or hematologists to ensure comprehensive care, and patients may initially present to any of the other specialties. Additionally, greater awareness can drive research funding and innovation for better treatments, as well as foster public support for patients living with the condition.
You've mentioned a few symptoms. What are the key symptoms and why does it often take an average of 4 years for patients to receive a diagnosis?
Pulmonary hypertension is a slowly progressive disease, and it's not until at least 50% of the blood vessels are affected, usually before patients develop symptoms. And it's slowly progressive, so their symptoms come on slowly and are usually mild in the early stages. Symptoms are often non-specific, such as fatigue, breathlessness, swollen ankles, and patients often mistake their symptoms for being unfit or aging or developing asthma. And the presentation of such non-specific symptoms for a rare disease contributes to the delay in diagnosis. There was a paper published by Jeff Strange showing that in Australia, patients reported on average 5 general practitioner visits, 3 specialist reviews, and a delay of nearly 4 years from symptom onset to a diagnosis of idiopathic PAH. It's particularly higher risk for females, although males have a longer delay to diagnosis, and for patients with connective tissue disorders, positive family history, sleep apnea, pulmonary fibrosis, emphysema, and thromboembolic disease.
Tell us about the main treatment options available and how have they evolved?
Well, main treatment options would include general measures and pulmonary hypertension and group-specific measures. So the general measures would be structured physical activity, lifestyle measures such as salt reduction, smoking cessation, alcohol reduction, avoidance of medications that may induce or exacerbate the condition. Patients of pregnancy age are advised to have contraception because there's a high maternal mortality risk. We advocate that patients are vaccinated with influenza, COVID, and pneumonia vaccines. And some patients may require oxygen therapy at home or during aeroplane flights. And anticoagulation for chronic thromboembolic disease is vital, and diuretics are often required by most patients. If we go into the specific therapies for PAH, these are aimed at increasing vasodilatation of the pulmonary vessels. Blood vessel wall contraction is controlled by endothelin, prostacyclin, and nitric oxide pathways, and as a result, these 3 pathways are the main focus of current treatments. There are prostacyclin analogues such as inhaled iloprost, intravenous epoprostenol or oral treprostinil, or prostacyclin receptor agonists such as selexipag. We have the nitric oxide donors such as phosphodiesterase 5 inhibitors, sildenafil and tadalafil, or soluble guanylate cyclase simulators, riociguat. Endothelin receptor antagonists commonly used would be ambrisentan and macitentan, although historically bosentan was the original. We use calcium channel blockers such as diltiazem if there's vasoreactivity during right heart catheterization. And then for chronic thromboembolic disease, we would consider pulmonary endarterectomy, which is surgery to remove the blood clots, or balloon angioplasty to open up scar tissue. Lung transplantation is reserved for isolated severe cases or unresponsive patients. And group 1 PAH patients have the best response to medical therapy. Now, if we look at the reason we put patients into groups is it directs treatment. So the treatment for all the different groups is often different. And so the treatment for group 2 or left-sided post-capillary pulmonary hypertension is directed at treating the left side of the heart or heart failure, and really is based around fluid management such as diuretics, SGLT2 inhibitors, and aldosterone antagonists, and correction of any valvular disorders that they may have. Group 3 PAH, which is primary lung disease, does not respond to conventional group 1 pulmonary arterial hypertension therapies, but often oxygen will be prescribed, and occasionally we'll give a 3-month trial of sildenafil. Group 4, which is chronic thromboembolic disease, is the only type of PH that may be cured surgically or improved with interventional balloon angioplasty. And often we will use additional medication if they are unsuccessful or incomplete in full recovery with using riociguat or an endothelin antagonist. The disease has progressed and the treatment's progressed in knowledge over the last 40 years. In the early days, we only had intravenous prostacyclin as the only effective therapy. But in the 1990s, there was the introduction of endothelin receptor antagonists and PDE5 inhibitors. And now there's more recent advances in combination therapies. Initially, it was monotherapy, then dual, then triple, and now even quadruple therapy, and different modes of delivery, such as inhaled or injectables. There's also a lot of ongoing research into newer agents that actually are disease modifying by changing the signaling pathways that control proliferation and constriction. And the focus has really shifted from merely lowering pulmonary pressure to enhancing right ventricular function and prognosis, and using disease modifiers to reduce the abnormal cell proliferation and fibrosis. But research continues to refine treatments and explore curative options.
So now we're going to introduce Associate Professor Fred Joshua. Why is it particularly important for patients with rheumatological conditions and their GPs to be informed about pulmonary arterial hypertension, or PAH?
Thank you, Sally. I think pulmonary arterial hypertension is a serious and progressive condition characterized by the high blood pressure in the pulmonary arteries, which can lead to right heart failure, which Martin explained. And I think for rheumatological problems, we often have people who have significant fatigue, shortness of breath for many reasons. So this can lead to an underdiagnosis. For patients with rheumatologic conditions such as systemic sclerosis, lupus, or rheumatoid arthritis, it's critical for a few reasons then that we identify it. People who have systemic sclerosis or scleroderma, they have a much higher rate of developing this, and it's up to 10 to 15% of patients with it who may develop pulmonary arterial hypertension. And it's one of the leading causes of death in the group. So I think when we're trying to determine whom is at highest risk for our patients with rheumatological problems, it's this group that needs particular attention. But that then leads sometimes to us not recognizing other conditions in rheumatology that are also associated with pulmonary hypertension, such as SLE, where it's less common, but it is still around 0.5 to 14%, and some larger groups have found it at least at 5%. It's often associated with Raynaud's phenomena and antiphospholipid antibodies, though the exact mechanism is less clear than in systemic sclerosis, where it's often vascular proliferation. In mixed connective tissue disease, it's estimated to be between 4 to 20%, though there isn't as much data on this group. And I suppose then we also have people with rheumatoid arthritis where it's quite rare and typically below 1%. But these people also are likely to develop problems from interstitial lung disease. So it is important that we still recognize it. Other conditions such as Sjogren's syndrome, it's quite uncommon, but still around 1 to 5%. And inflammatory myopathies, again, around that 1 to 5%. But interstitial lung disease can have a large role to play in these conditions in resulting in secondary pulmonary hypertension. More rare rheumatological diseases, such as vasculitis, and have a much lower rate, but ankylosing spondylitis, for example, would have it quite uncommonly, though they can also develop interstitial lung disease. The early diagnosis is hard because the symptoms of shortness of breath, fatigue, or swelling can be pretty subtle and mistaken for the other issues that people with rheumatological problems have. So we often have a delay in diagnosis. And it's important because early detection improves outcome, and it's manageable with the therapies that Professor Brown has already gone through. So if we don't recognize it, we can't get them onto treatment and improve their outcome. And finally, the collaboration is really quite key. Our general practitioner colleagues often are the first people to see these patients and can coordinate the care and often help us to improve outcome by referring and bring it to our attention, though we would often be screening. Education empowers us both to recognise the red flags and push for the specialist referral, because it is a specialised group that need to see patients with this problem.
What are the key investigations used to diagnose PAH? And you've crossed over this before, but how can early detection improve patient outcomes?
So the diagnosis of pulmonary hypertension requires the investigations of a chest X-ray, ECG, the autoimmune screening blood tests, thyroid function, sarcoid screening tests, which often include blood and imaging, pulmonary function tests, cardiopulmonary exercise test, and the 6-minute walk test, as well as Doppler echocardiogram, VQ scans, and high-resolution CT scans. So there's a lot of testing that's involved. But I think as we broach the topic and start to identify, at least with echocardiogram, the start of it, we can get a better chance of making an earlier diagnosis. Definitive diagnosis is determined by right heart catheterization, and it's generally performed via the neck in the internal jugular, and sometimes the elbow or groin with the basilic or femoral vein to directly access the blood pressure in the heart and lung. And sometimes we need to use a vasodilator challenge to assess reactivity of the pulmonary vessels, and or fluid challenge to assess for the stiffness of the heart. And that can be done at the time of right heart catheterization. And sometimes to try and improve the pressure, they will ask people to do exercise on an exercise bike to try and improve the procedure results. It's really important because once we have a definitive diagnosis, it allows us to treat, and it can be a way of not just improving symptoms, but also improving outcome and life expectancy in the longer term and quality of life. So, early diagnosis, better investigation, and improved treatment is really the key here.
And how is PAH treated?
As outlined by Martin, there are a number of different treatments that are involved depending on the group, and it's evolving over time, as Martin had pointed out. And what I think is really important through all of this is the recognition of the underlying condition, which can help to identify it, but also to help with the therapeutic choice. The vascular remodeling that occurs over time makes it more difficult to treat. So that's why we really want to try and find it early. And it may have a bearing on what we do. For specific conditions, it's important, and particularly with SLE, there is some evidence that suggests that even immunosuppression in early disease may reduce pulmonary arterial hypertension. So if we look at some of the specific conditions such as systemic sclerosis associated pulmonary arterial hypertension, it's from mainly vascular remodeling and fibrosis and seems to be more independent of systemic inflammation. Treating the systemic sclerosis may not reverse established pulmonary arterial hypertension, but it might improve and slow progression. So we often will use medication to try and treat systemic sclerosis. That's immunosuppression, often medications such as mycophenolate or cyclophosphamide or rituximab, and even moving towards drugs such as IL-6 medication when we're thinking about the systemic component. But there's limited evidence that that really improves pulmonary hypertension. So we then think about mainly the treatments that Martin had gone through with endothelin antagonists and even multiple medications. Other drugs for systemic sclerosis, such as anti-fibrotic agents, such as nintedanib, may improve outcome, but we haven't got as much proof of that in pulmonary hypertension. With SLE, it can be linked to active inflammation. So I think that is probably the area where we could make a difference with immunosuppression beyond just using the standard therapies that Martin had gone through. And aggressive control may improve it. And because there's the component of antiphospholipid syndrome as well, we may need to think about anticoagulation as well. The other conditions, such as mixed connective tissue diseases, very limited. And in rheumatoid arthritis, we have not been able to link it to the disease activity, but more around interstitial lung disease and then a secondary vasculopathy rather than active synovitis. So looking for the interstitial lung disease is the key. And again, this treatment would be mainly for people to have the standard therapies for pulmonary hypertension that Martin had gone through.
You may or may not have covered this, but what factors influence treatment decisions for different patients?
So, for the different patients, I think we have touched a little upon this. And I think when we're trying to really determine what to do, we are trying to look at the group, and that's the main way we would think about treating. So, group one, the more idiopathic connective tissue diseases, group two with left-sided changes, etc., that Martin had said, would determine most. And then I think for us, the other component from a rheumatologic perspective is looking at what causation and whether we can improve the immunosuppressive component that we would use for other rheumatologic conditions. The other component of it that makes a big difference are the patient-specific factors, such as age and frailty, and elderly patients may have reduced functional status, so tolerate aggressive treatments less. Comorbid conditions like renal impairment or liver dysfunction can limit drug choices. So when we're trying to select what drug we're going to use, we might have the underlying rheumatologic condition, their status in general from a functional class, their hemodynamic parameters, then their patient-specific factors that we'd use, and then thinking about whether there are any interactions from a drug perspective, and finally tolerability. So our clinic in particular provides this patient-specific care and resources to help the patient get the best therapy really by the coordination of their care and even access to clinical trials.
Associate Professor Martin Brown, from a cardiologist's perspective, why is a multidisciplinary team approach crucial in managing pulmonary hypertension, and how does this model work at Macquarie University Hospital?
So, pulmonary arterial hypertension, as you've heard, is a very complex disease with multiple etiologies and comorbidities often interplaying. And this creates a complexity of diagnosis and also a complexity of management. So when we have all three specialties, and we'll often have two respiratory physicians, two rheumatologists and two cardiologists in our clinic, they get to have three specialist opinions or even six simultaneously, rather than having to traipse around Sydney or New South Wales, arranging multiple appointments with multiple specialties and then correspondence going between those providers. What we provide, we all see the patients in the room at the same time. They get an hour with one of the consultants. That consultant then presents the case to the rest of the group with the patient in the room. We then discuss all the results and the nuances of their disease and thrash out ideas and treatment plans in real time in front of the patient, so that by the end of that consult, they have a clear understanding of what their diagnosis is and what our management plan will be. And they get the opportunity to ask any of the specialists their questions that they have, whether it's rheumatological, respiratory, cardiology. And so I think patients really appreciate listening about how we discuss their disease, and how we're going to treat it, but also having the opportunity to ask any one of us their questions. And this allows us to expedite their treatment, often reducing it from an average of 8 months to 1 month before they commence therapy. And it reduces the time taken to start treatment, but it also hopefully will improve their prognosis, and they get very tailored specialist care.
Associate Professor Fred Joshua, from a rheumatology standpoint, how does collaboration with cardiologists and other specialists improve patient outcomes?
I totally agree with Martin that it's impossible to have that free flow of information so quickly and adjust decisions without the coordination of the whole team. So having the information at hand, having this patient-centered approach where, as Martin had said, we can answer the questions and look at the nuances of what each person is going through, and then think about it in real time and then make a decision that then is actioned, is really useful. And it allows best practice, I think, because we can make sure we're having peer review all the time. It's also logistically so much better for the patient and for us, because we'll often be waiting to try and sort out a problem. We can just expedite the whole process. A simple example would be patients wanting to go on holidays and then having their medications fixed up, having, say, oxygen provided because it was a logistical issue that we needed to cover off. So I think it allows a much better free flow of information and coordination of people's care. And we all learn more actually from each other.
Yeah, I agree. I mean, I've learned so much about rheumatology from Fred and pulmonology from the Benning and Amy McLean, that my knowledge is expanded as well. So I think in our clinic it's very collaborative and quite enjoyable actually, because we learn a lot ourselves as well as about pulmonary hypertension.
It's very hard to get high level quality care and be thinking about complex problems and then getting a different viewpoint at at the real time. And so you can have missed something, and then you suddenly are exposed to why this is a better decision, and it just makes for better medicine.
So, Martin, what research and clinical trials are currently underway at Macquarie University Hospital for pulmonary hypertension, and how could they impact future treatment options?
Thanks, Sally. Well, we started the pulmonary hypertension clinic over 10 years ago, and since that time we've performed 11 worldwide international clinical trials in PHT, mainly phase 2 and phase 3. And we do it for several reasons. The main one is it gives patients earlier access to new treatments that wouldn't otherwise be available in Australia for the next 5 or 10 years. But not only that, it's fully funded. So these patients get access to very expensive treatments and they're paid for. So the primary reason for doing clinical trials is for the patients. But it also allows us as physicians to learn about new treatments, learn new methods, learn new basic science about the disease. And I'm constantly learning and looking things up myself about these new therapies. And I think that then allows us to be more forward thinking in our whole treatment plan and discussion with our colleagues. We're also part of the PSANS registry, which collects our patient data and outcomes and is combined with the whole of Australia and New Zealand. And that is used to lobby government for extra funding and review of new therapies and funding of new therapies and treatments. So that's a major benefit to the pulmonary hypertension patients. We also currently have 3 trials running. For Group 1 PAH, we have 2, Advance with oral ralinepag versus placebo, and Procera, which is inhaled seralutinib. And in left-sided heart disease, or Group 2, we have the APEX study just started. This is using a drug that activates relaxin, which is a chemical released in pregnancy by women to relax their tissues. And we're trying to use it to see if it relaxes the stiffness of the left heart and reduce the backflow into the pulmonary artery. Next year, we have 2 more trials in the pipeline for interstitial lung disease, PAH, and Group 1 PAH.
And Fred, in your view, how is research enhancing our understanding of pulmonary hypertension in patients with autoimmune or connective tissue diseases? And what advancements do you see on the horizon?
Research is really deepening our grasp of connective tissue disease, pulmonary artery hypertension, by dissecting out molecular and clinical nuances and moving beyond this one-size-fits-all approach. On the horizon, we're likely to see more precise therapies. Immunosuppressive agents such as IL-6 and JAK inhibitors are currently being evaluated. Antifibrotic treatments, nintedanib and pirfenidone, gene-based CRISPR-based approaches targeting BMPR2, which is a key pulmonary arterial hypertension gene. And those are the more mechanistic methods that are being used and drug treatments, but then even early detection via biomarkers and advanced imaging to optimize care through combination strategies, and the technology is also very much on the horizon as we are able to stratify those that need more effective treatment more quickly.
Thank you to my special guests, Associate Professor Martin Brown and Associate Professor Fred Joshua. This podcast is sponsored by Macquarie University Hospital, part of NQ Health, a trailblazer in healthcare, education and research. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.